Well, good evening and welcome everybody. My name is Julia Priestley and I'm one of the joint CEOs of the BTF. We're very pleased that so many of you have joined us for tonight's meeting. And as well as patients, I think we've got a lot of medical professionals who've registered and are taking part, so you're all very welcome. This is the first Meet the Expert webinar for 2023, and we're delighted to start the year with a topic we've not previously covered. Our speakers are two of the UK's leading experts in the field of thyroid cancer. So they're just the right people to be giving you a thorough overview and diagnosis and treatment of thyroid cancer, as well as to give an update about the very latest research and clinical trials that are currently taking place. And it's also a great privilege to introduce you to our chair this evening, Mrs. Nancy Prest. Nancy is the chair of the BTF trustees and is herself a thyroid cancer patient. So she has a very personal insight and understanding into the issues that we'll be covering and we're discussing. In a moment, I'll pass you over to Nancy, but before I do, just a quick plug for the BTF and the work we do to support people living with a thyroid disorder. Almost all of our funding comes from membership fees and donations. So if you'd like to support our charity and enable us to continue to provide free information events like this, then please consider joining the BTF. You can do that for as little as £19 a year, or you could make a donation if you'd like to support us, however small that is, would be very grateful. So that's all I need to say. And so now I'll hand you over to Nancy, who will introduce our speakers.
Thank you, Julia. Well, welcome everybody. I'm very privileged this evening to be on this call with our guest expert speakers, Day Kim and Mark Strachan. And I'd like to thank them as well for taking the time to join us tonight. Thank you so much, gentlemen. Day is a consultant, ENT, neck, head and thyroid surgeon for the Royal Marsden Hospital, and Mark is a consultant and endocrinologist at the Western General Hospital in Edinburgh, as well as being a trustee for the BTF. So this evening we aim to try and keep within the hour. We are going to hear firstly from Day and then we'll hear from Mark. If you have any questions, please put them in the comments section and we will be able to answer them hopefully at the end. I will be able to see them and no one else will, so you'll be fine. I will make sure that we get through as many as we can. So Day will start by looking at the diagnostics, the epidemiology, the surgery, and also starting to look at the follow-up from surgery. And then we'll pass over to Mark, who's going to look at the iodine, the follow-up and the medication that you will be taking, such as T3 and T4, and I suppose what will happen in the future. Hopefully, everyone will enjoy this and you'll learn new things. But first of all, I'd like to welcome Day and say thank you very much. And we're ready when you are.
Thank you. Can you hear me okay?
Yes.
Good. I'll share my presentation. So here we go. Can you see my presentation? Yeah, great. Well, thank you very much, Julia, Nancy, and BTF for this opportunity. Today, I want to just give an update on what's been going on in terms of thyroid cancer management, and particularly focusing this time on early cancer, which makes up the vast majority of the new diagnosis that we see. So 4 aims. I want to set the scene, and I think this will explain why there's been changes and how we've adapted to try and manage the massive increase in workload. And then some of the new treatment recommendation that you may or may not be aware of, and actually the variation in practice, which is important. And then I'll just touch upon follow-up care, really, just to link in with Mark, who will obviously go through the detail, because that's the complex part, and I'm just a surgeon. So first of all, what's happening in the world of thyroid lumps and cancer? So when I was in medical school, I was told that about 1 in 20 have thyroid lumps, but things have moved on now. And just by ultrasound, if you were to just go out in the streets and any lady or man around 50 years or above, then half or even 2/3 will have thyroid nodules. So they're very common. almost endemic, and we call them incidentalomas. They don't cause any symptoms, the patient's not aware of it, and frequently now we see lots through MRI, CT scan, PET scan when they have it for other conditions. Unfortunately, thyroid cancer can exist in these. We can't ignore them just because we found them incidentally. So we need to do the right thing for for those patients. Now, when we look at thyroid cancer, it too has been changing a lot. So over the last several decades, it's been going up exponentially. The left graph, if you see, is that all of it, but the majority, this papillary version, which is the most common version. If you look at the middle graph, what you'll see is that this increase are in the very small ones, the ones up to 1 centimeter, and those between 1 and 2 centimeters. And those that are larger than 2 centimeters, and certainly the larger ones, have stayed very stable. So these are the ones that were presenting anyway, because you could see them or they were symptomatic. So what these graphs show very nicely is that we're picking these early cancers. Now, what's important is that although the number of cancers we're detecting are increasing, actually overall rate of mortality, these are patients dying from thyroid cancer, the same. And it's not because we're any better. I think the question is, are we picking up those that we've never picked up in the past before the era of all these complex investigations? And therefore, do we really need to treat them because they haven't been affecting the mortality rates? The patient haven't been dying from them. So maybe we need to rethink about how we treat these patients with these early and smaller cancers. Regardless, if you picked up, clearly it's an anxious moment. You may have had an ultrasound for another cause and suddenly they tell you you've got a thyroid nodule. So the ideal way is that there will be a rapid 2-week wait thyroid lump clinic, or sometimes a head and neck lump clinic. And in that clinic, you should be seen within 2 weeks, and you usually see the consultant surgeon. And they will assess you comprehensively. And if you need a nasal endoscopic examination of your airway or vocal cord, that will be done at the same time. And ideally, if it's set up, you should get an ultrasound and a biopsy on the same visit, although this is variable in terms of service delivery at the moment. But that's the ideal scenario. And that clinic is backed up by clinical nurse specialists that can provide social support and other informational support. And also there is a comprehensive MDT, which is a multidisciplinary team that's composed of pathologists, radiologists, surgeons and oncologists that will review every single case, so that your recommendation of treatment and our assessment is not based on that one clinician that you happen to see. So that's the setup for any new thyroid lump clinics in the 21st century. So what are we looking for? So there's two things that's important. Firstly, it's called a U classification. So that's the U for ultrasound. And what we're looking for is to risk stratify. That's all it is. Rarely do we get an answer. So what we want to know is this lump that's we found, how risky is it? And it goes from U1 to U5. So U1 is normal, U5 is highly likely that there is cancer in there. And then I can't see it myself because of this, but on the right-hand side, there is an approximate percentage of cancer risk. So radiologists look at the ultrasound scan and trying to place you either in U2, U3, or U4. Depending on their experience and whether they're thyroid specialist or a general radiologist, this can vary. So you may go to one radiologist, they'll call it U3, and then it may go downgraded to U2 or upgraded to U4. So it's not that this is an exact science, but this just guides whether we need to go to the next step, and that's to take a biopsy, because that's more important, that's more accurate. And so a lot of people, when they have a slightly suspicious nodule, i.e. U3 or higher, then you'll be recommended to have a biopsy, which is done at the same time. They just freeze your skin up and then put a small needle into the nodule and try and take some cells from this. And once again, we have this classification, and this is called the Thigh classification for thyroid. It goes from 1 to 5, and again, higher the number, the riskier that lesion is. If you have Thigh 5, which is quite rare at the bottom, then you've got almost a 98, 99% chance that this is cancer. But like I said, that's quite uncommon. And the majority will get a Thigh 2. Often, patients will sit in the Thigh 3 group, and these are the suspicious nodules, and normally the clinicians will recommend a diagnostic surgery just to remove this and to be sure. So For example, if you're a Thy3F, then you have a 15 to 30% chance that there's cancer in there, and up to 85% chance there is no cancer in there. Now, I think this is the most important bit, and this is what's changed a lot. And I want patients mainly to know and be in control of their care. So back in 2004, my good friend John Watkinson was part of the BTA guidelines on thyroid cancer. And at the time, anything more than 1 centimeter proven thyroid cancer should get total thyroidectomy and then radioactive iodine afterwards. But over the 10 years after that, there's been lots of studies, and they showed that actually maybe we're over-treating, that many of these, particularly the what called low risk meaning less than 4 centimeters without any adverse features, maybe they can do equally well with just half a thyroid and maintain a functioning thyroid, and they have equally low recurrence rate. And as a result of this growing evidence, the BTA and the ATA, that's the British and the American Thyroid Association, came and promoted something called what I call personalized, i.e. up to the patient, per patient decision, and it's de-intensification to reduce treatment. So no longer one hammer fits all, but they say if in carefully chosen patients, and if it suits their surveillance and their management plan, and after talking to them about all the pros and cons of each option, then a hemithyroidectomy without radiodine may be suitable for these patients, although accepting a slightly higher recurrence rate. So that's the fundamental change from back in 2004. So not everyone may benefit from a total thyroidectomy. But there's a problem. Now we've widened the treatment option. Now you have do a hemithyroidectomy or a total thyroidectomy. And clearly there were concerns that there was variation around the country. So we did a survey in conjunction with the British Thyroid Association, Butterfly, and the Thyroid Cancer Forum. And we surveyed the whole of UK. That's 53 thyroid MDT, so pretty comprehensive. And the fundamental summary was there was a marked and quite concerning variability and inconsistency even within its own MDT in decision-making and the treatment recommendations for patients. Each MDT seemed to disagree which patients were actually low risk. And then there is another paper. So let's just go back. And then there's another paper which I'll present, and this is on the other side in the US, and they show exactly the same concerning variability. For example, so we asked these surgeons and oncologists, if there is a young lady with a 2 centimeter thyroid cancer, then what would your local MDT suggest? And then you can see from the graph on the left-hand side that the majority, i.e. 57%, recommended a hemithyroidectomy, although a third would still go with a total thyroidectomy. Now, what if the scenario involves a similar young gentleman, but with a 3 centimeter cancer? That's what's slightly bigger, 1 centimeter bigger, but still within the less than 4 centimeter category of low risk. And you can see that it's flipped now on the right graph, that now 2/3 would prefer total thyroidectomy versus much less hemithyroidectomy. And this goes against both guidelines. Either you give total to everyone, or you give hemi to the low risk. But as you can see, even the clinicians are getting confused now. So this is a summary graph, and we looked at all the different major thyroid cancer centers. And if you look on the right side, the blues, they still offer mainly total thyroidectomy. The majority will offer around 75 to 90% of their patients will get total thyroidectomy, whereas those units in the yellow, it's the opposite, 75 to 80% will get hemithyroidectomy, and those in the white, they say, we leave it to the patient to decide, 50-50, which is unfair, given that the clinicians are confused, what can the patients decide upon? And so this is a very recent paper. This is in 2022, that's just last year. And they looked at the practice in the US, very similar to ours. And so they saw a massive variation in treatment decisions. They also saw that different doctors quoted different complications for operations. They also saw variation in risk assessments. So if you had a patient with a 2 centimeter thyroid cancer, what's the chance of recurrence? And it varied between 1 and 53% chance of recurrence, which is quite startling. Now, you'd think that if I felt that I could offer more aggressive surgery to reduce the risk of recurrence, or I could offer less surgery and preserve function, that this would have an impact on decision, but this was not the case. The overriding fundamental factor that decided what the patient was going to end up with was not the patient wishes, but what the surgeon prefers to do. That's very clear, and that maintains. So we felt that we needed to provide patient with with accurate information so that they can make an informed choice. And so this is where I come in specifically. I'm a chief investigator for the multi-center UK trial called HOT trial. So this is the hemithyroidectomy or total thyroidectomy in the majority of patients who have low risk thyroid cancer. And this scale diagram shows that there are benefits and disadvantages of each option. And I think we as clinicians need to tell patients accurate information on what those disadvantages and advantages are so they can make the right decision that suits them. Now, I'm just going to finish up with follow-up care. So this impacts on follow-up care. So in the past, everyone got total thyroidectomy and probably radioiodine. And we have a very comprehensive and tried and tested way of what's called risk stratified follow-up. And I think Mark will go into that in more detail. And often it involves annual follow-up with thyroglobulin, which is a specific tumor marker for thyroid cancer, your thyroid function level, and then using ultrasounds and other tests if there's any concerns. And then the thyroid suppression, which is to try and reduce any proliferation of any thyroid cells that may be left, then is used. And I think Mark will go into that further. But if you're a patient who has been who only received a hemithyroidectomy now, or chose hemithyroidectomy or recommended hemithyroidectomy, there's absolutely no consensus on how to look after you after your surgery. We can't use the thyroglobulin because you still have your thyroid gland. Ultrasound scan is very expensive and not very specific. We'll only look at recurrence just in the neck, or how about in the chest and elsewhere. And I know from our surveys, which is unpublished, that there's high variability in how you're looked after, especially with the pressures on the NHS these days. So in some centres, you will get an annual follow-up as per NICE guidance that just came out in 2022 for 5 years. However, in many centres, you will not get any ultrasound scan and just have clinical follow-up. And in some centres, you may be discharged after 1 or 2 years. So this is really concerning, and we hope that the recruitment into the HOT trial will provide the information. I think that's key for our patients. So in summary, thyroid nodules are very common, and we're finding more and more. As a result of that, we're finding lots of small cancers. Maybe we should be treating them less or with less aggressive techniques. The gold standard investigation you should have is an ultrasound guided biopsy, and this will give you a risk, almost a number, a risk stratification of what that nodule, how risky that nodule is for thyroid cancer, and you can make your informed decision. There's a trend now towards only doing hemithyroidectomy for many of our patients versus total, that radioiodine is likely not recommended for these patients, or certainly can't for hemithyroidectomy, but even for the total thyroidectomy patients. And in some centers, active surveillance for small thyroid cancers are coming as an option. So finally, I think it's critical that clinicians, and you should ask for this as patients, that you have what's called shared decision-making. So you make the final decision, the clinicians provide the information that you need, and you choose the treatment that suits your lifestyle, your age group, and your expectation, as there are pros and cons on each treatment option. And the final 3 bullet points are that for more aggressive and more advanced thyroid cancers, we're going into an era of gene testing guided targeted therapy and using aggressive surgery with systemic therapy for our anaplastic thyroid cancers, where we're seeing significant benefits. But that's not the focus of this talk. So I'll come to an end there, and hopefully there'll be some questions at the end, and I'll be happy to answer them. Thank you.
Thank you, Dave. That was really interesting. It's very different from when I first had and was diagnosed with my cancer 18 years ago. So in 2004, I was firmly under the camp of John Watkinson, where I had the total thyroidectomy and the radioiodine. Really intrigued now as to how they might treat me a bit differently, but we will never know. And we have also got quite a lot of questions about the HOT trials, and which we'll come to after we've heard from Mark, who will be looking at, I suppose, the post-operative and the post-treatments. So Mark, over to you.
Thank you very much indeed, Nancy. Let me now just see if I can work the technology and share my screen. Okay, now I'm hoping you can see my slides there.
Yes.
Excellent. Okay, so yeah, I'm really just going to follow on from what Dave was saying, and actually I'm going to be saying in many ways the message that I'm going to be giving is very, very similar to what Dave has just been saying. So Dave's obviously spoken about surgery, which may be hemithyroidectomy or may be a total thyroidectomy, either in itself in 1 or 2 stages. There might be lymph nodes removed if they're identified before surgery. And then traditionally, the majority of patients with thyroid cancer would have gone on and had radioactive iodine, although as Dave said, that is very, very much changing now. And we've got different dose options that we can give of the radioactive iodine. We've got different ways of preparing you for radioactive iodine. And then again, traditionally, the majority of people would have been given levothyroxine replacement therapy to lower TSH levels. But in the same way that surgical practice is changing, practice around radioactive iodine and levothyroxine suppression is also changing. They mentioned the 2014 British Thyroid Association guidance, and now the new NICE guidance on thyroid cancer. And these really should be guiding all the MDTs in the United Kingdom in their practice. But in all of these guidelines, there are always grey areas. It's not always black and white. And as Dave said, the key goal in the MDT decisions around thyroid cancer are to try and individualize treatment and to get the treatment just right. We're trying to avoid over-treating people with low-risk cancers, but obviously it's really important that we avoid under-treating people with higher-risk cancers. And this is where this whole business of risk assessment comes to play. So Dave mentioned the risk assessments that are done at the time of the initial ultrasound scan and the initial biopsy. These are all, these risk assessments are working out, well, what operation do you get? Once you've had an operation, there is then a further risk assessment that's performed to assess the category in which the thyroid cancer is placed. So in general, and these are a bit wordy, these slides, so I apologize, but it's an important concept to try and get across. But in general, people are considered lower risk if there's no evidence that the cancer has spread out with the thyroid. If it's clear that the surgeon has managed to resect all of the cancer. There's no evidence that the cancer has invaded into local structures in the neck, and that the cancer doesn't have what we call high-risk histological features. So that's things that we look at or the pathologists look at under the microscope that we know are markers of higher risk. That might include evidence that there are cancer cells in tiny blood vessels within the cancer, or specific subtypes of the papillary and follicular cancers. Intermediate risk people are individuals where there is evidence of invasion of the cancer microscopically into tissues in and around the thyroid, or there's evidence that the cancer has spread to lymph nodes in the neck. And that also includes people who have some of these high-risk features when they're looked at under the microscope. The highest risk individuals are those where there's clear evidence that you can see cancer that has invaded out with the thyroid. It's not just microscopic, it's actually visible to the naked eye. And high-risk individuals are also where the cancer has not been able to be completely removed by the surgeon, or if there's evidence that the cancer has spread out with the neck area. So that's the immediate post-operative risk stratification that's done to then guide the next stage in treatment, in essence, the requirement for radioactive iodine therapy. Now, radioactive iodine is, in principle, is a very simple treatment. Iodine is taken up by thyroid cells. It's taken up by thyroid cancer cells. And if we make the iodine radioactive, then the radiation, in theory, will kill the cancer cells. That is the basic principle. We call the initial dose of radioactive iodine, or might be the only dose of radioactive iodine for the majority of people, an ablation dose. Now, the reason it's called an ablation dose is nothing to do with cancer. It's actually to do with ablation of normal thyroid cells after the initial surgery. So no surgeon, even a surgeon as skilled as Day, can remove every last piece of thyroid at the time of an operation. There are always tiny microscopic pieces that are left behind. Those normal thyroid cells make thyroglobulin, which I'm going to speak about later, which is a thyroid cancer marker. But it's only a cancer marker if you have no normal thyroid left. So what that initial ablation dose of radioactive iodine does in the main is kill any normal thyroid cells left, any normal thyroid cells that have been left behind after the operation. And what that means then is that any thyroglobulin that is still detectable afterwards, we know is likely to be coming from residual cancer cells. So the ablation dose of radioactive iodine allows us to use thyroglobulin as a cancer marker. The other benefit of radioactive iodine ablation is that you get an uptake scan, or you can perform an uptake scan after the treatment is given. And that lets us see if there are any areas of uptake out with the neck area, which might be indicative that the cancer has spread. That ablation dose may also treat any residual microscopic areas of cancer that have been left behind after the surgery. But in many ways, that is a secondary benefit of the ablation dose. The primary benefit is around the ability to ablate normal thyroid tissue and to use thyroglobulin as a cancer marker. If there is known to be residual cancer after the initial surgery and after that initial ablation dose, then we can give higher doses of radioactive iodine, which we would consider as therapeutic doses of radioactive iodine that are specifically targeted against residual cancer cells. So radioactive iodine is generally always given to people with high-risk cancers. And I think it'd be fair to say it's still given to the majority of people with intermediate risk cancers. And it may also be given to people with lower risk cancers, particularly where the initial primary tumor is more than 4 centimeters. In some centers, it will be given to people with lower risk cancers between that 1 to 4 centimeter size that Day mentioned, and that is that variation in practice that we do know exists across the country. There are different doses that we can give, a lower dose and a higher dose. And again, that dose that's given is usually determined at the MDT discussion and is based on the risk category of the patient. So if the individual is in a high risk category, they will generally be given high dose. Whereas if they are in a lower risk category, they will be given the low dose therapy. Thyroid cancer cells don't take up iodine as well as normal thyroid cells. And so we have to prepare the body, we have to optimize uptake of radioactive iodine by any residual cancer cells. Traditionally, that was done by stopping levothyroxine, usually, sometimes for up to 6 weeks, so that the person became profoundly hypothyroid. TSH levels were very high, and that encouraged the cells to take up the iodine. These days, in most centers, recombinant TSH is now used, so an injection form of TSH, which avoids the need to withdraw levothyroxine. Now, you might say, well, why don't we just give radioactive iodine to everybody? And we don't give it to everybody because there are downsides to it. And again, this is where the risk and the balance has to be weighed up. For a start, radioactive iodine is a real hassle to get. Those of you who've had radioactive iodine will know that you often have to go into an isolation room in your local cancer center. You may have to spend 1, 2, 3 nights in the isolation room. You then have restrictions in place around contact, particularly with young children and women who are pregnant in the days after discharge from hospital. We know that radioactive iodine is also taken up by other tissues in the body. It's primarily taken up by thyroid cells, but other tissues also take it up, particularly the salivary glands. So people who get particularly multiple doses of radioactive iodine often can get a very distressing dry mouth because of the hit that the salivary glands have taken from the radioactive iodine. Radioactive iodine is a radioactive treatment, and we know that radiation can, in theory, cause cancers in itself. Now, we believe that the risk of second cancers from radioactive iodine is extremely small, and that the risks of those second cancers is far outweighed by the benefits of radioactive iodine in people with higher risk disease. But this again is where we're trying to avoid over-treating people by giving people with very low-risk cancers where the chances of them coming to harm from that thyroid cancer are really very small indeed. We want to avoid giving those individuals radioactive iodine because in there, the downsides might outweigh the benefits. TSH suppression is with levothyroxine is a very logical treatment. We know this is a complicated slide, but broadly, TSH, thyroid stimulating hormone, as its name implies, is a growth factor for thyroid cells, and it's a growth factor for thyroid cancer cells. So if you give a high dose of levothyroxine, more than the normal physiological dose, that will lower TSH levels in that individual. And so the theory goes, by lowering the TSH levels, you are cutting off a potential growth factor for any cancer cells that have remained behind after surgery and radioactive iodine. And there is evidence from research studies. They're very old studies now, and studies that are not without their sort of mechanistic difficulties. But there is evidence that people with thyroid cancer who have TSH suppression have a lower risk of recurrence or progression of their cancer. But again, in the same way that radioactive iodine in theory can be harmful, the same is true of TSH suppression. We know that people who have TSH suppression in the long term are at increased risk of a heart condition called atrial fibrillation, where your heart goes very fast and can beat in an irregular fashion. And it can also lower bone density. So particularly in older people, atrial fibrillation and osteoporosis are more common in the general population anyway. But if you have a suppressed TSH, your risk of these things is higher. So again, in the modern management of thyroid cancer, what we're trying to do is offer TSH suppression where it's needed, but not give TSH suppression to people who are in lower risk categories. We know, and I'm sure some of you on this webinar today who've had thyroid cancer will attest to what I'm going to say, is that we know that people who have had thyroid cancer, if you look in general terms, that they have a lower quality of life than in the general population. Symptoms of anxiety, low mood, poor sleep quality, palpitations, tremor, they're all more common in people who have had thyroid cancer. And in part, some of those symptoms may relate to TSH suppression, because as I said earlier, you can only suppress TSH if you're given a dose of levothyroxine that is more than you would normally be exposed to physiologically. So it's a supraphysiological state. There is no evidence, though, that T3 replacement is particularly beneficial in people who have thyroid cancer, either from a quality of life point of view or from a cancer point of view. Now, when I say there is no specific evidence, that's because those studies generally haven't been done. Most studies of T3 replacement are done in people with hypothyroidism, non-surgical hypothyroidism, Hashimoto's disease, and other autoimmune forms of hypothyroidism. So when I say that there's no evidence, it's more a lack of evidence rather than the fact that there have been negative studies. But unfortunately, that is the situation that we are in at the moment. And of course, T3 has its proponents, and it has people who don't support the use of T3 in general terms, and T3 does have its downsides as well as theoretical benefits. Now, I just wanted to say a little word about thyroglobulin. So thyroglobulin is basically a protein that is made in thyroid cells. So as I said earlier, normal thyroid cells make thyroglobulin. Thyroid cancer cells also make thyroglobulin. So thyroglobulin can be used as a thyroid cancer marker predominantly in people who have had a total thyroidectomy and ablative radioactive iodine. They should, in theory, have no normal thyroid cells left in their body. As Day said at the end of his talk, if you've had just a hemithyroidectomy, you still have half of your thyroid there. And so that other half of the thyroid will make thyroglobulin. So thyroglobulin in that situation isn't a specific thyroid cancer marker. Thyroglobulin is not the easiest protein in the world to measure in the blood. And we know that, and I think I've got a slide, my next slide shows this, that different assays will give different thyroglobulin levels. So one of the important things in long-term follow-up is that your thyroglobulin is measured on the same assay. Now, if you're attending the same clinic, that should be the case, unless every so often labs decide to upgrade their equipment and they change manufacturer. But you can get that the same person can get different thyroglobulin measurements depending on the assay that's used. So you have to be very careful in the interpretation of thyroglobulin levels, particularly if, as a healthcare professional, the levels are coming from a different laboratory that you're used to. As a general rule of thumb, though, a rising thyroglobulin is the thing that is particularly an alert sign for us in terms of long-term follow-up, as a sign of potential recurrence or growth of thyroid cancer. One other thing that can make thyroglobulin tricky is that you can get antibodies in your blood against thyroglobulin. These are found in 10% of the general population, and maybe even a higher proportion of people with a history of thyroid cancer. Now, these antibodies in themselves are meaningless. They don't do anything at all. They're just antibodies that you've probably generated against a virus infection at some point in the past. But just as a quirk, those antibodies are able to stick to thyroglobulin. The problem with thyroglobulin antibodies is that they can make the laboratory measure of thyroglobulin inaccurate. And so it just makes follow-up more tricky. This was the slide I said, that each color here, the blue, the red, and the orange, is a given thyroglobulin blood sample that's been sent to 10 different laboratories, numbered 1 to 10. And what you basically see there is the range of thyroglobulin results that those laboratories give. So you can see if you are patient number 6, say, for example, in one laboratory, you're given a result of nearly 15, and in the other laboratory, you're given a result of 5. Now, neither laboratory is wrong. It's just that these assays measure just slightly different facets of the thyroglobulin molecule. But you could see that if you were going to laboratory number 1, or rather, say like you were going to the red laboratory, and then you moved and you went to the laboratory, a hospital that used the blue laboratory, it might appear that there's been a sudden rise in your thyroglobulin levels, whereas in reality, there's been no change at all. It's just a different assay. So that's why consistency of thyroglobulin assays in long-term follow-up is important if it can be achieved. Now, another risk stratification slide. So Day mentioned, as we said, risk stratification prior to your initial operation that determines what operation you have. I then mentioned the post-operative risk stratification that determined whether or not you get radioactive iodine or not. And we then have another risk stratification, which is done at 9 to 12 months after surgery and radioactive iodine. And so this comes under the label of what we call dynamic risk stratification. And what this is doing is looking to see how you have responded to the treatment that you've been given. So you may have been in an intermediate risk category, but we're now looking to see, are you still in that category, or has something got worse, or actually have things got better as a consequence of the treatment? And that risk assessment, that dynamic risk assessment, uses the thyroglobulin result, and it uses a neck ultrasound scan result, usually done, as I say, around about 9 to 12 months after surgery and radioactive iodine. TSH suppression is generally not given to people with low-risk tumors that don't require radioactive iodine, or in a smaller proportion of people, if the risks of TSH suppression would outweigh the benefits, if there were concerns about your heart, concerns about your bones that might mean that that's not recommended. If you have a single focus of a microcancer, then the new guidelines say then you may not require any routine follow-up at all. But as they implied, if you have a cancer that was more than 1 centimeter, but was in a low-risk category, so you had only a hemithyroidectomy, then follow-up for up to 5 years with ultrasound is what is now recommended. And in both of those categories, TSH suppression is not required. Long-term TSH suppression, aiming for TSH below 0.1, is given to everyone who gets radioactive iodine until the time of the dynamic risk assessment at 9 to 12 months. And it will be continued after that dynamic risk assessment if you're in what's called an incomplete response category. So that basically means that you've still got detectable thyroglobulin at a moderately high level, over 1, or your thyroglobulin levels are rising, or you're known to have evidence of persistent cancer in your body. So there is known to be a cancer deposits in your body after that initial treatment. If you have an excellent response to treatment, and by excellent, that means that at dynamic risk assessment, you have a thyroglobulin that's below 0.2, and you have a neck ultrasound scan that shows no evidence of structural disease, then that initial TSH suppression that you were given to below 0.1 can be eased off, aiming for a TSH between 0.3 and 2. The new guidelines say that you should be followed up for between 2 and 5 years with periodic, usually every 12 months, measurement of thyroglobulin. And if after 5 years your thyroglobulin remains below 0.2, then you may be safely discharged. These are the new guidelines. That's obviously different from what was historic practice, where people would often remain under very long-term follow-up for 10, 15, 20, 25, 30 years after their cancer treatment. And often with TSH suppression being maintained, even though thyroglobulin was undetectable. And then we have an intermediate category where TSH is kept at between 0.1 and 0.5 for 5 to 10 years. And that's if you have what's called an indeterminate response at that dynamic risk assessment. So that's where you've got thyroglobulin is measurable, but not at particularly high levels. Or you've got changes on scans that are non-specific. We're not sure that they are anything. They might be something, but they might not be. And I've also included in here, if you have anti-thyroglobulin antibodies where we're not certain that we're getting an accurate measure of thyroglobulin, then often in that situation, we'll keep the TSH suppressed, but not fully suppressed. So I hope I've not confused you with what I've said there, but what I'm just trying to emphasize, the key sort of take-home message in all of this is that we're trying at multiple points along your journey to assess risk of the cancer coming back or the cancer progressing. But at the end of the day, the reality is that most people with papillary and follicular cancer of the thyroid have an excellent prognosis. And what we just have to avoid doing is over-treating people who have a very good prognosis that we know is likely to be a good prognosis right back at the beginning. But of course, to avoid under-treating people with cancer at the highest risk. And that, Nancy, is all I was going to say.
Wow, thank you, Mark. We have had a comment from someone called Dan who said that they feel that this should be something that's given to all new patients, as it's very informative. And Dan, I can agree. 18 years ago, I wish I'd had this much information. And it's quite interesting to know that I'm actually now, I was classed as an indeterminate response. And that's why 18 years later, they are finally looking at signing me off, so to speak. And now I fully understand what TSH, thyroid globulin, what it all means. Thank you, Mark, Day, it's been wonderful. We do, however, have some questions if you're able to take a few.
Yep.
We have, Day, we've had quite a few on the hot trials. So I know you've answered some of this in the chats, but what is it? What's the hot trials? Who is suitable? Who can join them? How do you go about joining them? How do you find out more? And someone's asked the specific question that if their hospital isn't doing the hot trials, can you go elsewhere to be a part of them?
Yes. The hot trial is aimed at the majority of the new cancer diagnosis that we see. So anyone with anyone with a cancer size less than 4 centimeters is potentially eligible. Mm-hmm. Within that, there will be some fine adjustment just to make sure there are no high risk features, maybe a very strong family history of aggressive thyroid cancers, maybe in the children, maybe there are some features on the pathology once it's removed. So there are those fine tuning elements, but certainly anyone with less than 4 centimeters should be potentially eligible. So that's the main take-home message. At the moment, we've got about 20 sites around the country, including Scotland, open. We're hoping to have 30. So you should, most patients should have access to this. Now, what it may be is that the hot trial is open at the centre, but your surgeon, for some reason, has not involved in it, if you know what I mean. So there is an ethical premise that an NHS funded trial should have equal access. And therefore, all patients should at least be told, if it's within their hospital, that this exists. If it doesn't exist in the hospital, potentially you could move to a hospital that does, but it would mean that you may need to travel, and so you need to factor that in. The hot trial is a high quality trial. We want to once and for all answer a question that all different nations, America, Australia, Canada, are asking. What is the best treatment for our patients? And we don't have this. For example, we don't have information accurately on what is the recurrent laryngeal nerve palsy rate. So you'd be told by the surgeon, or the hypocalcemia, you'd be told by the surgeon what they think it is. But there's never been a study that other people have audited a surgeon's outcome. And this is the first. It's quite frightening what it will be. Okay. And so the patients will be followed up very rigorously, 6 monthly initially, then annually, with blood tests, quality of life questionnaires to find out how they're doing, what issues they're having. It's all done online on an app on the phone, and then they'll have an ultrasound scan every year for 5 years. So comprehensive, regardless of which arm. And there's 2 arms, obviously. There's the hemithyroidectomy and total thyroidectomy. And as trials go, to allow so that we don't get biased in terms of selecting the patients that we like, we have to randomize. So when you enter a trial, you are randomized to either a hemi or total, so we have equal number of patients at the end to answer this question. And clearly patients may have their own preference, what they want. But the aim of this is to get an answer without introducing human bias. Okay, the care that you get, regardless of which arm, is comprehensive and the same follow-up. Okay, it's a non-inferiority trial, which means we don't believe that either arm or either treatment has anything significantly inferior, and certainly there should be no difference in recurrence rate. Okay, so that's what the trial is. I think I've answered most, and I've done a reply in terms of where you get more information. So you can go to the BTF website. You have the sites that are open. You can go to CR UK website and just pop in hot trial. I've also uploaded the UCL clinical trials unit that run the trial, and then you can go to the Butterfly Cancer Trust website and they will have similar.
Brilliant. Thank you, Dave. there's quite a few questions. I've kind of grouped this together as a bigger question. Might be more towards Mark, but Dave, feel free. If you've had a total thyroidectomy, I suppose it's the aftercare. So obviously, as Marky was saying, you can have, I suppose, side effects to being suppressed. And people are asking, what can they do? And this is a question I would also like to ask about weight gain or weight loss. If you've got hair loss, brittle nails, tiredness after the thyroidectomy, and whilst you're having the suppression, how do you go about getting some help?
Well, those sort of symptoms, in my experience, are common after a thyroid cancer diagnosis. What is always difficult to know is whether those symptoms are because of the fact that the thyroid has been removed and you're now on levothyroxine, and maybe the hormone levels are not quite right, or whether it is a consequence of all you've had to go through with that cancer diagnosis. You know, again, I probably don't need to tell anybody on this call who's lived through it. You know, it's a horrendous experience. The uncertainty, the worry, the physicality of having gone through a general anesthetic, an operation, the uncertainty about your future, your work. All of these things have a very, very negative effect on our well-being. So some of the symptomatology that people can experience may be a consequence of that. Some of it may be due to the fact that, yeah, the hormone replacement is just not quite right. That the levels aren't quite right. It may be because we're giving you a dose of thyroid hormone that is actually higher than you've ever been used to before, because we're trying to suppress TSH. So it is a nightmare. You know, it is very, very difficult. My best advice as a general rule is, if you have access to a thyroid cancer nurse, then that is probably your best person to contact immediately afterward, because they may the thyroid cancer nurse may not be able to help you immediately, but they might be able to put you in contact with people that can help you. And that, you know, that's probably the best thing that you can do. But also have a discussion with the healthcare professionals that are involved with your follow-up, you know, just around, you know, what is my TSH level? Am I at the right level that you want it to be at? Can we improve that in any way? That's probably, as a generic response, the best that I can say.
Does the for the ladies out there, does the perimenopause and menopause have any effect?
So I don't think it has any. I don't think it has any negative effect in terms of cancer prognosis. But of course, if you're already feeling rubbish because you're perimenopausal or going through the menopause, then everything I've just said is amplified further, because you're starting off from a baseline where, again, you're not feeling great. So it's just a further thing that just adds to the negative experience that you have to go through.
Mm-hmm. Yeah, it's not fun.
Nancy, can I just say something? Do you mind?
Mm-hmm. Yes, feel free.
So as Mark said, it's not so clear cut what the causes may be for many of the symptoms and the reduced quality of life. I think what's important, I'd like to emphasize, is that then having a hemithyroidectomy is not your answer. So up till now, most people have had total thyroidectomy, radioiodine, and so we've built up this database of potential associated symptoms and issues. So if now you say, well, actually, they've given me hemi now, I can avoid all of that. That's not the case. We just don't know. Although that cohort is increasing, there are other problems having hemithyroidectomy provides. It's equally low quality of life, regret, concerns, anxiety. So what I want to make sure is that you don't say immediately, I'm just going to have a hemithyroidectomy. That's not it, okay? So please don't be biased by the potential to have these kind of symptoms just after a total thyroidectomy. That's all it was. Thank you.
Very good point. And we have a lot of questions, and I'm conscious that we only have a few minutes left. So we'll try and rattle through a few more. If somebody has, I think this is about metastasis. So if somebody has a glands or lymph nodes that have thyroid cancer cells in them, maybe not all of them, it could be 1 out of 3. Is that classed as metastasized? Or I can't say that word, or does it, because it's gone from the primary, from the thyroid, or does it mean something else?
So I'll maybe start off, and then I'm sure Dale will want to come in. So yes, so metastasis basically means that the cancer has spread from the primary site. So classically, in the case of papillary thyroid cancer, which of course is the most common, the classic site that it will metastasize to are lymph glands in the neck. Initially in glands that are located centrally, and then it can also metastasize to lymph glands that are further out in the neck. And that is something that surgeons like Dave are all over like a rash. So at the time of surgery, in an ideal world, if possible, those glands will be removed at the time of the initial operation. But Dave, you might want to say more about that.
Yeah, so technically speaking, it is metastasis because it's spread outside the gland. It's nodal metastasis as opposed to the metastasis that we may think about to the brain and the lung and various things. Completely different. That's distant metastasis. Okay. Now the important thing about thyroid cancer is that they do spread outside of thyroid cancer very early and in most. So there are lots of studies showing that if you have a 1 or 2 centimeter thyroid cancer, even though the ultrasound and PET scan, everything's clear, if you go looking and remove these glands, you'll find them in about 50%, I'm afraid, okay? But we don't think they do anything. They may die if you remove the thyroid, especially if you give you radioiodine. We don't think they do anything. And actually, even when you don't give radioiodine, we don't think those little microscopic spread does anything. So I think that it's a good question, but the fundamental care and the treatment outcome takes into account all of these factors and much more in providing you with the best recommendation. I hope that helps.
Yes, that's quite. I wish I'd known that. Mine had spread, but as you say, it's more local. Do we have time for at least one more question? Thank you. We've had this asked in many different ways. So social media and people saying things on social media. There's quite a few comments here about the balance of hormones. So like taking supplements like magnesium and zinc, looking at your diet, cutting out carbs and stopping using endocrine disruptors such as candles and cleaning products, and all of these things having effects on white blood cells. Is there anything, any external factors that do have an effect on us when we're taking high levels of thyroxine or thyroxine? That's a big question.
That's a difficult thing to. I'm going to turn that around. I'm going to sound like a politician when I say that. I think if you find as an individual that taking supplements like selenium and magnesium is of benefit to you, then there's no problem with doing that. I cannot point you to any high quality research study where people have been randomized to dummy versus active that says that taking supplements like that is unequivocally of benefit. But what I can say is that it's highly improbable that taking supplements like that would be in any way harmful. So if there are changes that you've made to your diet, that you've made to, in terms of vitamin supplement regimes that you find of benefit, absolutely no problem at all. But I think that's probably more sort of an individual voyage of discovery that you might need to go on to find that, rather than anything that I could specifically say to you, yes, that will make a difference for you.
Okay. And one final question, if we have so many questions, I'm so sorry everyone, we can't go through them all, but this I thought was quite an interesting one. What happens if someone's allergic to thyroxine?
Well, I think I've only ever come across true allergy to, well, I'm not sure I've ever knowingly come across true allergy to thyroxine. So the first thing I'd say is that levothyroxine is a natural thyroid hormone. We cannot, levothyroxine is made in the thyroid gland. Now, what we take as a levothyroxine tablet, of course, is not just pure levothyroxine. It's got preservatives in it. It's got bulking agents in it. And between different brands of levothyroxine, those preservatives and bulking agents will differ. So it is theoretically possible that someone may have an adverse reaction to a tablet constituent, but it would be highly, highly unlikely that it would be an allergy to the levothyroxine molecule, because before that person became hypothyroid, their thyroid would have been making levothyroxine. So usually if someone has a significant intolerance to levothyroxine tablets, some endocrinologists will recommend having a particular branded form of levothyroxine, and that's a trial and error to see. Again, I'm personally not a massive fan of that, but I know that that is done by some endocrinologists. And in other instances, a trial of liothyronine T3 replacement might be recommended, but that's something that should be discussed usually with an endocrinologist in order to determine if that's the case.
That's brilliant. Well, I'm so sorry, everybody. We have so many questions, but we've run out of time. I will, Julia, hello. Is there a way that we can answer more questions virtually, or?
What I will do is we'll go through all these questions and we'll pick up the ones that haven't been answered. You usually do a transcription of all the questions that came up in the webinar, and we'll also answer the ones that we'll add to them the ones which we didn't have time to answer. If anybody has got any specific questions that we didn't cover, or there's a follow-up, then do email them to us as well, because we do have a medical query answering service that we can help you with anyway. But if you just be patient, we'll in a few weeks' time we'll have this transcription of the Q&A from today, so you'll have those to refer to too. So I'd just like to say thank you ever so much to the amazing speakers. If I can get the right screen up. I got this. Hopefully that's the right screen. Thank you ever so much to brilliant speakers and such interesting and engaging presentations from you both. And thank you also to Nancy for your expert chairing and carefully curating all the questions that came through, the many questions that came through. And thank you as well to everybody who contributed their questions, which, you know, hopefully we certainly all learnt from. If any of you joined late, or there are bits you'd like to go back to and listen to again, we'll be adding a recording of the meeting to our website and to our YouTube channel in a few days' time, so look out for that. As I mentioned already, that further questions, we'll deal with them after the event. And if you've got questions that you didn't put into the chat, you're welcome to send them into our medical query service at any time as well. And finally, just a quick plug for our next webinar, which is taking place next Monday. And this might be of interest to some of you who are asking questions about well-being and weight as a follow-up to thyroid cancer. This webinar that will take place is part of our new BTF project, which is an online 12-week weight loss and well-being program. It's free of charge and it's open to anybody. So to find out more, just go to our website where you can register to start right away. And on our website also you can find details of the hot trial that Dave told us about. So once again, thank you very much to our wonderful speakers and to our chair, Nancy. We know how busy they all are, and so we're extremely grateful that they found the time to take part and to enable this to go ahead tonight. And finally, a thank you to all the people who joined us from home and to the questions that they contributed. Please stay in touch with the BTF, and we look forward to seeing you at our future events. Thank you and good night.